Okay, good morning, everyone. So my name is Michelle Science. I'm an infectious disease doctor from the Hospital for Sick Children in Toronto, and I'm going to speak to you this morning about COVID-19 and children. So just to start, I don't have any conflicts of interest to disclose. But I do want to acknowledge a number of people who provided some slides for this talk and some content. So Dr. Julia Orkin and the Sick Kids Vaccine Consult Service, two other ID physicians from Sick Kids, Dr. Ari Bittinen and Dr. Anu Wadwa, and also Dr. Daniel Warshowski from the Office of the Chief Medical Officer of Health. So in terms of the learning objectives for today, by the end of this presentation, I hope that you'll be able to describe the SARS-CoV-2 epidemiology in children in Canada and Ontario, to recognize the clinical features of SARS-CoV-2 infection in children, to outline the management of SARS-CoV-2 in children, and also to understand the benefits and potential side effects of the currently approved COVID-19 vaccine for children in Ontario. Okay, so I'm going to start by reviewing the current state of COVID-19 in children. And so this slide shows the pediatric cases in Canada as of February 4th, 2022. It actually summarizes all of the cumulative cases to date in Canada. And you can see it's grouped by age group. So 0 to 11 and 12 to 19 are the two pediatric categories. And so you can see there have been 337,000 cases in the 0 to 11 and over 275,000 cases in the 12 to 19. So that represents 11.2 and 9.1% of the cases to date in Canada of COVID-19. And so what you can see on the right there is that fortunately, while there have been a number of cases in the pediatric population, the severity indices have been relatively low. So on the right, you can see the hospitalizations, ICU admissions, and deaths, and the proportion of pediatric cases that have made up those outcomes. So generally less than 2%. So moving over to Ontario, this shows you what's been happening with the COVID-19 cases in Ontario since the start of the pandemic as of February 8th. And so figure on the left there shows the number of cases, and you can see the different waves that have occurred. And then more recently, you can see since mid-December, the large Omicron wave, which has led to a large number of cases related to its transmissibility. And on the right, this summarizes the total number of cases in Ontario as of February 8th in the pediatric age groups. So 0 to 4, there have been over 31,000, 5 to 11, 63,000, and 12 to 19, 90,000, over 90,000. And so important to note that you see a drop off or a significant decline in the number of cases as you approach January, mid-January there. But it's important to recognize that the eligibility criteria for PCR testing was restricted December 31st, 2021. And so the drop in cases reflects So knowing that case counts are becoming or have become a less meaningful metric to monitor, it's important to look at testing and percent positivity. So this summarizes the data in Ontario. On the left there, again, is since the start of the pandemic. You can see the total number of tests completed. And then the purple line there shows the percent positivity. So again, you can see how the percent positivity has increased over the different waves of the pandemic. And then most recently with the Omicron surge in Ontario, you can see how the percent positivity increased dramatically. On the right, you can see more recently how that's varied by the different age groups. And overall, you can see that the percent positivity has shown a slight decline since early January in all age groups, which is a potentially positive sign. So again, knowing that case counts are less meaningful, it is important to monitor hospitalizations and our hospital capacity. And this is from the Ontario Science Table. And it shows how the hospitalizations have changed since the Omicron wave. And again, on the left are all hospitalizations for all ages, so new hospital admissions. And again, you can see how that has dramatically increased since about mid-December, when Omicron became the dominant variant. And then on the right, on the left there, you can see that the pediatric cases, so the red, orange, yellow, and green age groups, represents a relatively small proportion of those hospital admissions. But when you change the scale and look just at the hospital admissions in pediatrics, you can see how the different age groups make up the cases. So children less than 1 in the red there does make up quite a significant portion of those new hospital admissions. This is just another way of looking at the hospitalization data and reviewing the rate per 100,000 population. So this is data from Public Health Ontario, and it summarizes the recent hospitalization by age group. So this is the hospitalizations in the 14 preceding days, and this is as of December 12th. So if you look at on the left there, it's the number of hospitalization, and the right, it's the rate per 100,000. You can see how 0 to 4, 5 to 11, and 12 to 19 have relatively low number of hospitalizations at that time, and the rates were low. So 0.3 per 100,000, 0.4, and 0.5 per 100 respectively on the top right there. If you look at what this graph looks like as of February 1st, so the counts have changed, as well as the rate per 100,000. So again, in that 0 to 4 age group, you can see how the rate has increased to 13.1 per 100,000. And we've similarly seen an increase in the 5 to 11 and 12 to 19 age groups. So 2 per 100,000 and 2.6 per 100,000 in those age groups, but still compared to the other age groups, a relatively low number of cases. And this is a slide from the Office of the Chief Medical Officer of Health. And again, it's just showing hospitalizations in another way. So this is as of January 29th, 2022. And so what I want to draw your attention is really the data that's coming out around vaccination in children and hospitalization risk. So this graph on the right shows you the 7-day daily average of children under 18 admitted to hospital. And so this is the trend that I've just showed you over the past few slides, where we have seen an increase in hospitalizations related to SARS-CoV-2. But you can see the age breakdown. So the 0 to 4, 5 to 11, and 12 to 17. And so the 0 to 4 are not eligible for vaccine, so none of them will have been vaccinated. But when you look at the 12 to 17 age group, you see that 13.1% were partially vaccinated, and 34.5% were fully vaccinated. So still quite a large number of children who have not been vaccinated. And it's even more pronounced in the 5 to 11 age group, where you see that only 1.3% of those hospitalized were fully vaccinated, and 7.9% were partially vaccinated. So what should we expect with hospitalization moving forward? This slide is from the Ontario Science table, and really shows us that there's considerable uncertainty around hospitalizations moving forward with the lifting of some of the restrictions January 31st. So we did see the increase in hospitalizations, and we will have to continue to monitor with the Omicron wave, and we'll have to continue to monitor as these restrictions have been lifted. And before moving on to the presentation, I'll just touch quickly on the pediatric critical care occupancy and mortality. I mentioned that already in terms of the risks to kids with COVID-19, the risks of requiring critical care and the risk of mortality is very low. And we have seen a small number of pediatric patients with COVID-19 related critical illness, but the numbers remain below our current critical care capacity. And mentioned already, there have been very few pediatric deaths, but no child deaths are acceptable, especially when they're preventable. So the clinical features, we've learned a lot about how COVID-19 presents in children, and really we continue to see a range of symptoms. So asymptomatic infection is common, and there's varying estimates in the literature ranging from up to 50 to 70% of cases being asymptomatic. When children do have acute COVID-19, it is most often a mild illness, similar to other respiratory viral infections. So fever, respiratory symptoms like cough, sore throat, changes in taste and smell, gastrointestinal symptoms like diarrhea, vomiting, and abdominal pain, and other flu-like symptoms like muscle aches, headaches, and fatigue. With Omicron, we have been seeing quite a bit of croup, as well as bronchiolitis related to acute COVID-19. A small minority developed severe disease like pneumonia and required COVID-directed therapy. Other clinical features include multisystem inflammatory syndrome in children, or MIS-C, which I will speak about in a little bit more detail, and then long COVID. And I'm not going to spend a lot of time speaking about long COVID. It's an area that we're continuing to monitor very closely. There's really a range of rates reported in the literature, but something that we need to monitor very closely. And we do have a long COVID clinic at Sick Kids where we see and follow patients. So in terms of those that are increased risk for severe acute COVID, what we've seen in the literature as well as at the hospital is that often there are underlying medical conditions when they have acute COVID that requires hospitalization. And I've included a number of references at the bottom there. There are a couple of large series that have reviewed risk factors for hospitalization, including a recent publication in JAMA Network Open just this week that summarized the experience in the US. And so some of the underlying conditions that have really come out as potentially being associated with an increased risk are obesity, type 1 diabetes, children with medical complexities, especially those dependent on technological support, immune suppression, chronic respiratory disorders, neurologic disorders, cardiac disease, genetic syndromes, and sickle cell disease. With respect to treatment or management, it's important to note that most children actually don't need any specific treatment for SARS-CoV-2. When children are hospitalized, supportive care is really the mainstay of treatment. So we have children that are admitted with diarrhea and vomiting and need IV fluids for supportive care. Some children will need management for croup, but most of the time it is supportive care. Occasionally, we will need to treat or provide COVID-19 directed therapy, and in children that tends to be dexamethasone and occasionally remdesivir. Other agents that are used more frequently in adults, so tocilizumab and the anti-SARS-CoV-2 monoclonal antibodies, so sotrovimab for Omicron, those agents are really not as commonly used in pediatrics, and especially with shortages and the fact that children often do very well. It hasn't really been a focus of treatment, but they are used on a case-by-case basis. And the bottom reference on the slide there, it is actually just draw your attention to it if you're interested. It is an external facing document that describes some of the management principles that we use, identifying those with mild, moderate, and severe disease, and which agents we would use in the various situations. So multisystem inflammatory syndrome in children is a potentially very severe complication of COVID-19. And symptoms tend to occur 2 to 6 weeks after acute COVID-19 infection and includes symptoms like fever, abdominal pain, vomiting, diarrhea, skin rash, and other signs of inflammation. And in terms of the demographic, it seems to occur at a median age in children with a median age of between 7 to 10. And our data specific to Canada is around 6 years old with a male predominance. So MIS-C is monitored both provincially and nationally. And in terms of our provincial data, up until June 30th, there were 42 hospitalized cases of MIS-C in the 5 to 11 age group. And that corresponds to an estimated risk of around 1 in every 2,162 COVID-19 infections in that age group. So I don't want to spend a lot of time on this slide, but there are case definitions of MIS-C. This one in particular is the World Health Organization definition. And just to draw your attention to the fever, which is a predominant symptom of MIS-C occurring for more than greater than or equal to 3 days. Other clinical signs of multi-system involvement, evidence of inflammation, and without another cause. With respect to management, we don't have any randomized clinical trial for children that are being admitted to hospital. They do have, which is the majority of cases with MIS-C, they usually have at least a brief admission to hospital. There's cardiac evaluation and monitoring. So this includes ECG, echo, and also blood work to monitor or to look at the cardiac enzymes. And then some of the treatments that we're using are steroids, IVIG, thromboprophylaxis, and then in refractory cases, occasionally biologic agents will be used. Okay, so I've sort of given an overview of some of the acute infectious implications in children, and I just wanted to summarize some of the other impacts. So beyond just infection, the COVID-19 pandemic has had a significant impact on children in other ways. And again, this is from the Office of the Chief Medical Officer of Health, this slide, and it just summarizes some of the other impacts of the COVID-19 pandemic on children. So not only infectious complications, but it's impacted physical health, mental health, and education. So in physical health, there are a number of studies looking at the implications, showing findings like more food, more snack, decreased outdoor activities, increased screen time, decreasing movement. With respect to mental health, there's some studies looking at increase in depression and anxiety, more screen time again, concerns around irritability, hyperactivity, and mood. And then the final bucket on the right there is around education and some of the impacts on education. And so educational losses throughout the pandemic. This is a science table brief that really summarized this topic. So students in Ontario have really experienced more periods of school closure than students in any other region in Canada between March 2020 and January 2022. So you can see there how it compares to the different provinces. And really, these are underestimates of the true educational losses because it doesn't account for individual classroom closures, related dismissals, or students isolated due to symptoms or being household contacts. Okay, so having reviewed now some of the infectious and non-infectious complications of SARS-CoV-2 in children, wanted to end and move on to talk about prevention. So the SARS-CoV-2 vaccine in children. And just for people that may be viewing this talk at a later date, this data is on vaccine is accurate as of February 9th, 2022. And so in terms of the vaccine timeline, it was about a year into the pandemic, December 2020, that the vaccine was authorized for 16 and up. In May 2021, the vaccine was authorized for children 12 to 15 years. October 18th, 2021, the application was submitted for 5 to 11 years. And then November 19th, 2021, the use was authorized by Health Canada for 5 to 11 years old. And shortly after that authorization, NACI came out with a recommendation around the vaccine use. So their recommendation was that a complete series of the Pfizer vaccine may be offered to children 5 to 11 years who do not have contraindications, with a dose of at least 8 weeks between the first and second dose. And this 8-week interval really came about to try to optimize the immune response. So just acknowledging that the immune response may be better with a longer interval between that first and second dose compared to the 3-week interval that was used in the published trial. And also that there may be less side effects, specifically myocarditis, with a longer interval between the two. More recently, NACI has come out strengthening their recommendation. So just to note that now they say that the vaccine should be offered to children 5 to 11 years of age who do not have contraindications to the vaccine, and they have stuck with the recommendation of an 8-week interval between the first and second dose. So now I want to talk a little bit about the benefits and potential side effects of the vaccine. And a lot of this is focused on that 5 to 11 age group, but it is also applicable to older children. So in terms of the benefits of vaccine for children, the vaccine can reduce the risk of infection, complications, and severe disease. It also reduces the chance of getting infection, and so therefore also transmission to other people. I spoke about the non-infectious complications or impacts of the COVID-19 pandemic. And so vaccine is one way to help keep kids in school and return to other in-person activities. And it also helps to protect our community. And so in terms of the risk of infection, complications, and severe disease, there's sort of 3 areas where evidence is emerging around impact on acute infection and disease severity, impact on multisystem inflammatory syndrome, and longer-term sequelae like long COVID, and the impact that vaccine may have on reducing these outcomes. So this was that original trial that I spoke about for the vaccine in the 5 to 11 age group. And I'll just highlight quickly that really in this trial, 2 doses was 90.7% effective in protecting against confirmed COVID-19 in the 5 to 11 age group using the 10 microgram dose. And this is something that we're continuing to see in the adult data. So this is from the Science table. Showing vaccine effectiveness and looking at it, comparing vaccinated and unvaccinated. So you can see the left is COVID-19 cases, hospitalizations, and then ICU admissions. And it compares the unvaccinated and vaccinated and the cases per 1 million. So you can see that it continues to be a dramatic difference between those that are vaccinated and unvaccinated with respect to these outcomes. And this is the data emerging in pediatrics around the vaccine having an impact on other complications like MIS-C and hospitalization. So the study on the left showed that 1 dose of vaccine had a reduced hazard ratio of developing multisystem inflammatory syndrome, and on the on the right is consistent with the data that we're seeing with hospitalization, showing that hospitalizations that children that are being admitted to hospital seem to be more often unvaccinated. So one of the questions that comes up is that a lot of this data is from pre-Omicron. And so how does the vaccine look for Omicron? And so this is data from Public Health Ontario looking at vaccine effectiveness against symptomatic infection. The squares are Delta, the gray circles are Omicron, and it shows essentially the vaccine effectiveness days since the 2nd dose and then days since the 3rd dose. And so vaccine effectiveness by infection caused by Delta is very good at 97% after the 3rd dose. But still important to note that for Omicron, although it's lower than Delta, it is still 61% after the 1st dose. And when you look at severe outcomes, the data looks even better in terms of the vaccine being effective for Omicron as well as Delta. So vaccine effectiveness for severe outcomes caused by Delta are 99% after the 3rd dose for Delta and 95% after the 3rd dose for Omicron. So here, this just summarizes in an infographic, this is from the University of Waterloo, some of the benefits of vaccinating children against COVID-19 in terms of reducing risk of illness, especially severe illness like pneumonia and MIS-C, improving or helping to make sure kids can continue to do the activities like go to school and extracurricular activities, and also reducing spread to friends and family members. So now just moving on to what side effects are experienced. And I realize I'm running out of time, so I'm going to go through some of this quickly. But in the clinical trial, important to note that there were no severe or serious adverse events related to the vaccine. There was no anaphylaxis and no cases of myocarditis or pericarditis. The most common side effects that were experienced were local, so injection site pain, and then systemic, so things like fatigue and headache. And myocarditis or pericarditis is something we get a lot of questions about. So I'm going to touch on this very quickly. So the symptoms usually occur between 1 to 7 days after vaccination. And we've seen most cases in males 18 to 24 years old. But what's important to note is that most of these cases are really are mild, and they respond to treatment with non-steroidal anti-inflammatory medications like ibuprofen and rest. We know that myocarditis also can occur or can be caused by infections from viruses like COVID-19. And the risk of myocarditis is actually 6 times greater after COVID-19 infection compared to vaccination. And it looks different. So the myocarditis from infection is more severe than what we see with myocarditis post-vaccination. So the last bullet point there just really summarizes the rate after the second dose for youth 12 to 15, which is 21 per million doses, so less than 1 in 10,000. And with the 5 to 11 year age group, we expected much lower dose rates because they're getting a lower dose of the vaccine. And this is data that was recently reported from the CDC, which really summarizes the experience around that. So the reported cases of myocarditis per 1 million doses administered, and you can see there, this is based on over 37 million total doses 1 and 2 of the vaccine administered. So again, if you look at the rates per 100 million doses administered, you can see how there is an age differences with age, and that 5 to 11 years is really much lower. Okay, so I'm going to end. Again, there's not much time, but wanted to talk about vaccine coverage very quickly. These are all from slides from the province, just summarizing where we are. So as of January 30th, 2022, our coverage in the 12 to 17, 87% with at least 1 dose and 83.4% with 2 doses. And in children 5 to 11, it's lower though. So 53.5% with at least 1 dose and only 18% with 2 doses. And there is a large variation across the province by public health unit, ranging from 38.3% to 69.4% with 1 dose. And we can see this with the first dose administration over time. So at the start, when the vaccine first became available and approved, you can see the large number of people that went out to get the first dose of vaccine. And that has really dropped off over time in terms of children having their first dose administered. And just to end on a positive note, this is the global vaccine uptake by 5 to 11 and shows Ontario's 5 to 11 vaccination rate compared to other provinces, as well as compared to the US and Europe and Israel. So compared to other Canadian provinces, we're a little bit lower, but still fairly comparable, but we're among the highest in the world compared to other jurisdictions. So with that, I'm really out of time. I wanted to thank you all very much for listening, and I hope I've provided you with some helpful information, especially answering questions to your patients or family members around questions about vaccine. Thank you.